In this presentation, we'll be discussing common eye disorders seen in primary care. My name is Dr. Tracy Murray, and I'm certified as an ACNP and FNP. I have over 20 years of experience in various settings as an APN, and I'm currently a full-time assistant professor with Chamberlain. Ophthalmology is a very specialized field and often intimidating to the primary care provider. The most important thing to know in this lecture is how to recognize a vision-threatening problem that requires an ophthalmology referral among the common eye problems that we see. Let's start with blepharitis. Blepharitis is an inflammation around the eyelid margins that is caused by staphylococcal infection at the lash bases and dysfunctional meibomian glands. It is often associated with patients who also have seborrheic dermatitis or eczema and is characterized by irritation, burning, itching, scales, and redness. The condition may last for several months or be chronic, but may lead to conjunctivitis, cellulitis, and keratitis. Typical treatment includes lid scrubs once or twice per day with baby shampoo and erythromycin ointment at night. Another cause of blepharitis is from lice. The cause is usually from pubic lice, rarely from body or head lice. Here's a great picture of both the nits and louse on the lids. The diagnostic characteristics of lice as the cause of blepharitis is that there will be a reddish-brown crust in the lashes, not white or clear as typically seen in blepharitis. The reason for this is because the lice live off blood, and the red-brown crusts are actually their feces. Ugh. Treatment is with petroleum jelly applied to the lids twice per day for 14 days. This drowns the nits, which hatch in 10 to 12-day cycles. Clothes and sheets should also be washed at the highest temperature. Suspect pubic lice from sexual transmission in teenagers. Children are often infected from a parent or an adult caregiver with pubic lice from their hand to their eye contact. Lids can also be infected by body lice from contact with chest or body hair. And of course, you do have to consider child abuse as well. Now, a chalazion is a chronic internal granulomatous reaction of the meibomian gland that produces a mass in the lid. Its onset is acute and is usually found in the mid-portion of the upper lid away from the margin. It's usually not painful or tender and looks slightly red but swollen. Treatment is conservative to start using warm compresses, time, and patience. Chalazions usually resolve in a few weeks to months, and antibiotic drops do not help. If there is no resolution within a few months, a referral to ophthalmology is appropriate for incision and drainage or steroid injection. One side note, squamous cell carcinoma looks similar, so again, if it's not improving, refer to ophtho. A hordeolum, on the other hand, is also known as a stye. A stye is an abscess of the lid margin caused by a staph infection. Styes have a very acute and painful onset associated with redness and swelling and are usually on the outside of the lid. Treatment is with warm compresses and topical antibiotics. One way to remember the difference between chalazion and hordeolum is, and this is in no way passing judgment on these people, but I use the mnemonic phrase, hoarders typically live in a pig sty. So hoarders go with sty. There are several types of conjunctivitis categories based on etiology, which includes bacterial, viral, allergic, toxic, and contact lens related. The cause of bacterial conjunctivitis, also known as pink eye, can include the following: direct hand-to-eye contact with an infected individual, spread of one's own nasal and sinus bacteria during an illness. The hallmark symptom of bacterial conjunctivitis is purulent discharge. Other signs and symptoms include reddened conjunctiva, both over the eyeball and inside the lid, and eyelid swelling. The infection can start off unilaterally, but often becomes bilateral due to contamination. The infection may resolve without treatment, but antibiotic drops can shorten the duration of the condition. Almost every antibiotic drop is effective in eradicating the bacteria and should be used 4 times per day for 5 to 7 days. The choice should be based on the patient's allergies, preference, formulary coverage, i.e. cost, and the availability. Instruct your patients to treat the eye that is affected, but to also start treatment in the other eyes if symptoms develop. It's important to teach the patient how to put drops in and advise to avoid touching the tip of the bottle to any conjunctival or skin surface. Women should be instructed to throw away all eye makeup products due to contamination and to start with new products when the infection clears. Likewise, disposable contact lens wearers will need to discard the contacts, refrain from wearing any during treatment, and start with a new pair when clinical symptoms resolve. Bacterial conjunctivitis is very contagious, so the patient should stay home from work or school until 24 hours of antibiotic treatment has ensued, or soon as clinical improvement is noted. There's one exception to the rule in regards to the effectiveness of antibiotic drops for all bacterial conjunctivitis cases, and the exception is gonococcal infections. Gonococcal conjunctivitis is sight-threatening because it can affect the cornea, so patients should be sent to the ER immediately. Gonococcal conjunctivitis is associated with hyperpurulent discharge. The next category of conjunctivitis infections are causes that are viral in origin. The majority of these cases are caused from the adenovirus, which is commonly associated with upper respiratory infections or the common cold. Other viruses associated with viral conjunctivitis include herpes simplex virus, HZV or zoster, and molluscum contagiosum. Signs and symptoms include irritation, mild light sensitivity, and swollen lids, and the patient may complain of a mild foreign body sensation. On physical exam, mild conjunctival hyperemia to intense hyperemia and watery or mucousy discharge can be seen. However, the drainage is not purulent, which is the distinguishing characteristic between bacterial and viral conjunctivitis. There are often enlarged tender preauricular lymph nodes on the affected side, and patients will have other nonspecific physical exam findings associated with an upper respiratory infection, such as a red throat, nasal drainage, ear infection, and so on. Point-of-care rapid adenovirus testing is available, but not commonly used in offices due to the high cost of the test in relation to reimbursement rate from insurance companies. So essentially, adenoviral conjunctivitis is a clinical diagnosis. Antibiotic drops are not effective, and viral infections are self-limiting, meaning they usually resolve on their own from a few days to a few weeks. Patients with adenoviral conjunctivitis need to understand that the condition is highly contagious. There are no firm guidelines on when a student can return to school, but the current AAO textbook recommends absence from work or school until redness or tearing has resolved. And the AAO stands for American Academy of Ophthalmology. Now, there are 2 types of herpes viruses. HSV1 typically occurs above the waist, and HSV2 typically occurs below the waist. An HSV conjunctivitis is spread by contact with persons who have visible infected lesions and with persons symptomatically shedding the virus, meaning the patient may be experiencing a prodrome of ill-related symptoms such as malaise, low-grade fever, pain, or tingling near the site of the lesions, but the lesions are not visible yet. Any of the following symptoms can be seen with an HSV1 or HSV2 conjunctivitis. Skin vesicles. If these are present, they often help with the diagnosis. Conjunctivitis, same as viral conjunctivitis, so it alone is not helpful in making this determination. And a corneal infection with the hallmark dendrite appearance, as you see here. A referral to ophthalmology is necessary, and typically you can get these patients in the same day if you call over to an ophthalmology office. If not, you might need to send them to the emergency room. Allergic conjunctivitis is usually caused by an environmental allergen such as pollen, grass, trees, and so on. Occurrence can be seasonal and can be isolated to the eyes or include upper respiratory allergy symptoms such as rhinitis. The hallmark characteristic symptom is itching. Other symptoms can include a diffuse milky conjunctival hyperemia, swollen conjunctiva, tearing, and symptoms are almost always bilateral. There may also be uniquely identifying bumps on the conjunctiva, which are called follicles, and when present are a hallmark symptom of allergy. Treatment is symptomatic, but it's important to advise the patient not to scratch, as this can result in a corneal abrasion and induces more itching by inducing the inflammatory response. Cool artificial tears, anti-allergy eye drops, either over-the-counter or prescription, can be helpful, but prescription drops are very expensive, so start with the over-the-counter ones first. Systemic antihistamines are not helpful for symptoms. Toxic conjunctivitis is due to overuse of topical ocular medications, such as Visine, but antibiotic drops are the most common. The classic scenario is the patient who continues to use the antibiotic drops prescribed for longer than necessary or when they're used for viral infections. Signs and symptoms include clear, watery discharge and red conjunctiva, so the diagnosis is mainly established from the history. Treatment, obviously, is to stop the drops. Contact lens conjunctivitis can be either acute or chronic. In an acute infection, the cornea is irritated and infected from lenses that are dirty or old, usually from wearing over an extended time. Chronic cases develop from an allergy or reaction to the contact lens itself or the solution that's being used. Now let's move on to traumatic injuries of the eye that you may encounter in the office. Traumatic injuries that are commonly seen in primary care include lid laceration, subconjunctival hemorrhage, corneal abrasions, foreign bodies, hyphema, ruptured globes, and chemical injuries. First, we'll discuss eyelid lacerations. Though not a sight-threatening condition unless there's penetration of the eye itself, eyelid lacerations will require repair, and it's often done in the operating room by the ophthalmologist. If a patient presents with an eyelid laceration, put gauze over the eye and send them to the ER with a heads-up phone call so that the ophthalmologist can be notified. Undoubtedly, you will come across a case or two of subconjunctival hemorrhage, maybe even during your clinical rotations. A subconjunctival hemorrhage is blood that is trapped under the conjunctiva. This can occur from direct trauma or from a sudden increase in pressure of the chest, which can be caused by sneezing, coughing, or straining with a bowel movement, vomiting, and strangulation, to name a few. Subconjunctival hemorrhages themselves don't cause pain. With mild cases without any signs of ocular injury, the condition is benign and will disappear within the week. There's no treatment necessary and no need for referral. And here is an example of a mild case. If the hemorrhage is moderate or severe, or there are other signs of trauma, or there is concern for more extensive eye injury based on history, a referral to ophthalmology or ER is appropriate. Make sure you do a vision test with any patient coming in with an eye complaint. In this case, if the vision is okay and the rest of the eye looks normal, there's probably no ocular injury and you can just reassure the patient. However, if there are signs of ocular trauma, such as irregular pupil or vision loss, this can indicate a more serious problem. Corneal abrasions cause a defect in the epithelial layer of the cornea only. The rest of the cornea is not damaged. Abrasions can be the result of trauma, foreign bodies, or chemical exposures. They're often extremely painful because of the numerous nerve endings in the cornea. Some other characteristics of corneal abrasions include extreme sensitivity to light and copious tearing. The patient may feel as if there's a foreign body sensation, which incidentally resolves with topical anesthetic, and they may also have trouble opening the eye. Diagnosis is made by means of fluorescein staining. The area where the corneal epithelial defect will light up with a bluish light when the fluorescent light is shined on it. To do this, you'll need to start by making the patient comfortable and the exam easier by instilling a drop of topical anesthetic. The effect should last around 20 minutes. Once numb, gently dab the conjunctiva with the dye stick and have the patient blink to disperse the substance. Turn off the lights and shine a blue light over the cornea to look for defects. It's a good idea to look for foreign bodies by pulling down the lower lid and looking under the upper lid. Be sure to irrigate the eye if there's suspected foreign body or chemical exposure. This picture illustrates a linear abrasion that is the result of a foreign body under the lid, as you see here. Treatment is to refer to ophthalmology. In general, abrasions heal quickly. Patching is rarely necessary but can provide some relief. Topical antibiotic ointment is recommended and pain medication will be necessary with close ophthalmology follow-up. Foreign bodies can occur in multiple locations, such as under the upper or lower lid, in or under the conjunctiva, embedded in the cornea, or they can penetrate the eye, as in the case of a gunshot wound. An urgent referral to ER or ophthalmologist is recommended. An eye exam will be required to rule out penetration. If the foreign body is embedded under the conjunctiva or sclera or inside the globe, surgery will be necessary for exploration and removal. A hyphema is where blood is trapped behind the iris and the cornea, which is the anterior chamber of the eye. Causes include blunt or penetrating trauma or can be associated with other eye injuries such as corneal abrasion or open globe. Treatment is to protect the eye with a patch or shield and refer to the ER or ophthalmologist. Once properly evaluated, if the hyphema is considered to be mild and there's no other damage to the eye and no increased intraocular pressure, the patient will require bed rest at home or in the hospital, steroid and dilating eye drops, and frequent ophthalmology visits within the first 2 weeks to assess for rebleeding. For severe cases, an evacuation may be necessary in the OR. Causes of an open or ruptured globe can also be from blunt or penetrating trauma. This is a vision-threatening injury and patients should be immediately referred to the emergency room after protecting the eye with a shield. This will require surgical repair, so make sure your patient doesn't have any plans to stop at McDonald's before going to the ER. Let's talk about chemical injuries now. The severity of a chemical injury depends on 3 things: the pH, the volume, and the duration of exposure. Alkaline agents are much more damaging to the eye than acids, and either can come in the form of liquid, solid, powder, mist, or vapor. Common acids include battery acid, bleach, and vinegar, which are sulfuric acid, sulfurous acid, and acetic acid, respectively. Whereas common alkaline agents include ammonia, drain cleaners, cement, plaster or mortar, airbag rupture, and fireworks. These agents contain ammonia, lye, lime, sodium, and magnesium hydroxide. Treatment is to immediately irrigate with water or normal saline using copious amounts of water, like a shower hose, or hose if needed. Do not use artificial tears or eye wash. The American Academy of Pediatric Ophthalmologists advocate that you send the patient in an ambulance to the emergency room. Acidic burns will produce large conjunctival and corneal abrasion and a mild corneal haze. Prognosis, though, is good for a full recovery. Alkali burns caused damage to the epithelium and deep corneal layer, which has a much poorer prognosis. In these pictures, you can see corneal scarring and vascular growth. So the takeaway points here with the chemical injuries are that acid injuries cause a corneal abrasion that typically heal with little to no corneal scarring. Alkali injuries that are minor cause a corneal abrasion that heals without a corneal scar. And alkali injuries, which are moderate or severe, cause permanent scarring and vision loss. Lastly, we're going to talk about periorbital and orbital cellulitis. These are two things that are very different in terms of the severity and importance of referring emergently to an ophthalmologist. So how do you get periorbital or orbital cellulitis? Well, it could spread from a local infection, such as a sinus infection or a dental abscess, or you can have a skin disruption or some kind, much like we get cellulitis in other areas of our body. Common pathogens include staph, group A strep, and strep pneumonia. The clinical difference between these two is based on anatomy and its location to the septum. Periorbital cellulitis is also called preseptal cellulitis because the septum separates the infection that is more anterior to going posterior. In other words, it's before the septum. In orbital cellulitis, the infection gets past the septum or comes from behind the septum. Now, there is a clinical difference between the two. In periorbital cellulitis, you'll see minimal pain, possible fever with redness, lid edema, and the patient doesn't look too sick. In this case, you'll treat with augmentin, ceftriaxone, or even vancomycin if there's concern for MRSA. Treatment can be oral antibiotics with close follow-up, but does not require a trip to the emergency room. As opposed to periorbital cellulitis, orbital cellulitis patients appear sick or toxic. Hallmark symptoms is mild to severe pain, especially with eye movement. Ethmoid sinusitis is the most likely cause. Physical exam findings, you'll see fever and the lids can look dark red and swollen. There is decreased visual acuity and underlying increased intraocular pressure. Pathogens include staph and Haemophilus influenza. One of the complications of orbital cellulitis is meningitis. So this is someone that you want to send to the ER right away. These people will require admission with further workup to look for an abscess in the orbit, sepsis, and meningitis. IV antibiotics are necessary.